go over ultrasound guided shoulder and knee injections. And so we're going to start off with our probe here, and we're going to go over our goals and objectives. So the first things is, why do we do ultrasound guidance? And then the other goal is to learn the basics for ultrasound guided shoulder and knee injections. We're going to quickly review some indications, contraindications, some benefits, some side effects, and complications of our injections. And then we want to identify some important anatomical landmarks for shoulder and knee ultrasound guided injections, both on the physical and on the ultrasound pictures. The last but most important part is going to be the hands-on practice for these injections. Let's see, we're going to go to, so why do you want to use ultrasound guidance? Well, ultrasound by itself is low cost, it's portable, it doesn't expose your patients to radiation. It actually enhances patient outcomes and experience. You can charge for a higher fee for service, but also it has improved outcomes. It's the big thing, right? So you can actually treat patients better with an ultrasound, doing these procedures with an ultrasound. So let's go over some of the indications why you would want to do an injection in the first place. Number one is it could be diagnostic. So you take a look at the synovial fluid and you get to see whether you have an infection there. Is it rheumatic? Is it traumatic? Is there crystal-induced pathology, so like CPPD or gout? It's also, and mostly, I'll be honest, that's what I use it for in sports medicine, is for pain relief. Usually for bursitis, impingement, tendonitis, or tendinopathy is why I usually do ultrasound guided injections. It's therapeutic, right, as well. So just relieving the pain tells you that the pain is where you did your injection, but long-term therapeutic wise is the ultimate goal. So either with a corticosteroid, or sometimes I'll use platelet-rich plasma to actually treat the underlying pathology. And you can inject lidocaine, saline, steroids. There's a whole bunch of things, so we'll go through some of that as well. So when would you not do an injection? So obviously, if there is a cellulitis overlying the area that you're trying to inject, or if you suspect bacteremia, if you have broken or open skin, you probably don't want to do these injections. If you have anticoagulant therapy or bleeding disorder, that would be another reason to not do an injection. It's a relative contraindication, right? So aspirin versus Plavix versus warfarin, how much bleeding will a patient have? If you actually have a septic joint, usually I'm not the one doing those drainages. If it really is septic, you have to send it to ortho so they can open the joint up and actually wash it out, clean it out. I also limit my steroid injections specifically to 3 injections within a 12-month time period. So if they've had 3, especially for a weight-bearing joint, so like a hip or a knee, I don't do more than 3. I think in my entire career, I did one time 3 injections on a woman who was going to get a hip replacement, and it really was just for temporizing pain relief. Even more so now, this is the case just because the studies are coming out and showing that steroids intra-articularly actually potentially can be chondrotoxic and actually have been shown to increase the formation of osteoarthritis. If the joint is unstable or inaccessible, obviously you wouldn't want to do injections in those joints. And it's more of a caution, but if the patient is diabetic or immunocompromised, depending on what you're injecting, if you're injecting steroids, they definitely will increase your blood sugar significantly. And if they're immunocompromised, it will further depress their immune system. So I actually have been getting this question a lot about whether patients should get a COVID shot after a steroid shot. I usually tell them to be safe, you probably should not. Now, let's say it's the opposite way around. If you get a COVID shot, I would wait at least 2 weeks before getting a steroid shot. So at least you can mount your antibodies before you put in some anti-inflammatory steroid injections. Obviously, if the patient is very anxious or just in your gut, if your gut says that maybe this is not the best thing to give the patient an injection, I would recommend not. Always listen to that sixth sense that you have about whether people should or should not get injections. Absolute contraindications. Obviously, if the patient is already septic, if you think they have septic arthritis, if they have hypersensitivity to any of the medications you're planning to use, if it's a traumatic injury, you should probably not be sticking a needle in it. Children, obviously, a lot of our injections are not good in children, especially children who still have their growth plates, if they're developing. And as we all know, males can actually grow with open growth plates into their 20s. So just be really careful about trying to do steroids in your adolescent and child population. If there's hemarthrosis, if there's a prosthetic joint, please don't go sticking a needle into a prosthetic joint. If it's very unstable, your needle is probably not going to help it. If there is a fracture, you can delay healing and actually cause problems. Or if the patient themselves is reluctant, I wouldn't recommend doing an injection. Equipment. So usually I have something to clean with. I prefer to clean with chlorhexidine. It's readily available in my clinic, but there are a lot of studies that show that just plain alcohol wipes work really well for these injections at preventing infection. I use an aseptic technique usually, so I am using non-sterile gloves, and depends on what you're doing. I usually use a 27 gauge all the way to as big as an 18 gauge needle, depending on what we're doing. And we can talk about those as we go through the different injections. I do have different sizes of syringes, depending on what injection I'm doing. Make sure you have culture tubes as needed. Anesthetic, I like to use a combination of both lidocaine and Marcaine, usually a ratio of 1:1. And depending what I'm doing, you'd be surprised how little volume you need to provide adequate analgesia for your patients with your numbing medication. And then whatever you're going to inject should be prepared. So like whether it's your steroid, your viscosupplementation, which is basically like Synvisc or Hyalgan, or a lot of times I've been doing a lot of platelet-rich plasma in my clinic nowadays. And then of course, whatever bandage and dressing you're going to dress your injection with after you're done. So please always consent the patient. Make sure you go over the risks and benefits and possible complications. Important ones, I always say pain, bleeding, infection. You can actually cause tendon damage if you're going into the tendon. If you're doing steroids into like a fat pad, you can cause fat pad atrophy. You can cause a white spot. And again, steroids will increase your blood sugar as well. Technique. So you always want to make sure you know what you're treating. If you think at all it could be a tumor or a fracture, make sure you x-ray those patients first before sticking a needle in them. You want to make sure you identify your landmarks on your physical exam and ultrasound. If you can't quite remember, please, Netter is our friend. Open it up and try to figure out where you're going first. Again, prepping, I clean with chlorhexidine, but alcohol is good as well as betadine. Depending on where I'm going, I may inject with a wheel of anesthetic first before providing anesthesia for the tract all the way into where I'm going. Examples are intra-articular shoulder or intra-articular knee. A lot of times, if I'm going to go in with a bigger needle later, I try to numb up first with a 27 gauge and a little bit of lidocaine and Marcaine. And then, of course, you use your bigger needle after that. So again, safety precautions, I like to use an aseptic technique. Obviously, if you're doing something like a line or whatnot, you'd want to use sterile technique. Adverse reactions, I have definitely had a lot of syncope. I've fortunately never had an anaphylaxis, but that is of course always possible. Syncope is the biggest potential side effect that I've seen pretty regularly. and always try to draw back prior to injecting whatever you're injecting. So let's start off with looking at the shoulder specifically. There are a couple injections, 4 injections that I do pretty commonly there. The glenohumeral joint itself needs to have an ultrasound. You can't get into the joint properly without an ultrasound. They've done lots of studies and they show that if you're not using an ultrasound, you're probably not getting into the joint where you want to be. The technique is so we're going to start here. You go posterior and you want your probe linear. So posterior, and you want it parallel to the floor, and you want it at the posterior joint. Your picture is going to be this one. This is a better picture. You can see the humeral head, and here is the glenoid on this side, and then you sometimes can see the labrum here as well. So this is kind of the picture that you want to see. So here's one with a little bit more labels. Again, the humeral head. This is the actual joint, and so we kind of call it a double bubble sign. So you'll see the capsule, the joint capsule, and then you'll see the actual cortex of the bone there. And again, don't go too close to this edge because your labrum is right there, your cartilage rim from your labrum, and then here's your acetabulum. And so, as you can see, the needle is coming in this way, and it's going right into, you can go anywhere within this capsule, and actually it'll diffuse into the joint itself. But I try to stay away from too close to the labrum, but kind of somewhere over the humeral head. I pretty much always numb first for this injection with a 27 gauge needle, and then I go in with I use a 3-inch spinal needle, so a really long one to get all the way down into that joint. You just need that extra length. My gauges for the spinal needle range from 22 to, I think I also use a 24 gauge needle, 3-inch. The biggest needle that I have for the spinal needles is an 18 gauge, but I usually don't use that for the shoulder. If anything, I sometimes use it for the hip. So the 22 gauge needle, usually I'll numb up first with a 27 and then go in with the longer needle after I completely come out, and then inject once you see the flash inside of that joint. Let's see our next picture. Now we have the AC joint. So the AC joint, as we know, is on top of our shoulder, right? So I like to actually keep the probe like along the clavicle and the AC almost. And so what you're actually seeing, this is going to be an out of plane injection, which I know you guys have learned about from Dr. Sacco. So you're not going to follow the needle. Like our previous one, you could see the needle in plane the whole time. So you see the tip of it all the way from the surface as you're going down into the joint. This AC joint is so superficial, it's really hard to do it that way. Because it's so shallow and superficial, I prefer to center my picture, and there's a line on your probe right in the middle. And so you're going to center it right here on your AC joint, and then your needle will go in the middle, straight up and down almost, until you get, and you can usually see the needle though as it comes into this joint. Again, it's really small, so you just kind of go straight up and down. Also remember how small it is when you choose how much steroids to use. So you probably don't want a large volume. I tend to do like maybe 0.5 ml of Kenalog, 0.5 ml of lidocaine, and 0.5 ml of bupivacaine when I do this injection. Okay. This is another picture of the AC joint, and you can kind of see where I've got the fluid in there, kind of diffusing in. And again, you may not see the whole needle. You're not going to see, the bad thing about out of plane is you won't see the tip of your needle. But if you're just going straight up and down, you can tell you're going straight into the joint that way. Yeah. Okay. And then this I left in here. This is just the picture that you find in AAFP that shows you how to do it blind. I used to do my AC joints blind, but since getting an ultrasound, it's way easier and you can feel reassured to get into the AC joint. It's a really small joint, again, because a lot of times what I used to do is kind of poke around until I got into the joint, and once it slipped in, then I would inject. But now I don't have any problems. Usually just with one shot, I can get into that tiny joint problem. This is probably the one that you guys are going to do the most. I will be honest, I do my subacromials without ultrasound majority of the time, but it is fun and it's nice to do it under ultrasound. So usually what you can do is look at that subacromial space. The biggest rotator cuff muscle is the supraspinatus muscle right there. It attaches to your greater tubercle. So you're kind of looking at the greater tubercle. On top of it, the next layer of muscle is the deltoid muscle. And then, of course, you have the humeral head. What you want to do is line up your picture, and what you're going to do is you can put the needle in plane, but you're going to try to get this space in between the supraspinatus and the deltoid. So as you can tell, you're not actually in the subacromial space yet, but that's where the subacromial bursa is, and it feeds right into that subacromial space. So if you just inject your steroid in here, it actually diffuses right into that bursa and into that subacromial space. Here's another picture where you can clearly see the needle going into that subacromial space. So a lot of times when people have subacromial bursitis, it's already enlarged, and you can just stick your needle right into that space and inject your steroid. And this is another way you can look at it. This is from the posterior edge in the back. And so this would be following almost traditionally what you do. From the back, you can again see your rotator cuff muscle, and it's slipping underneath this acromion. So in this injection, you will not be able to see your needle after it disappears underneath the acromion, but you can see how it's going still right in that same space. And as long as you're getting it under that acromion, you know you're technically in the subacromial space. This is, again, a picture from AFP showing that subacromial space blind. I usually direct my needle either little posterior lateral, and I direct it toward the coracoid process with a slightly upward angle. So again, it's kind of, again, with an ultrasound, it improves patient, comfort and outcomes. So definitely, you can use it for each one of these you do, but it's a lot quicker without an ultrasound for these. Biceps tendon, so the long head, this is where it's in the front. And so you're going to feel it. Usually I palpate it because you can feel it within the bicipital groove. And you're going to go straight up and down this way to see your bicep tendon in long view, so longitudinal view. You can also find it in short axis first. So I have some pictures of the short axis after this, but short axis first, and then rotate by 90 to find your really nice long head biceps, that long view. And again, you can see your needle coming in. You're following the needle the entire way from the surface till it gets right to that burst, to the tendon, sorry. Oh, this is the picture that I have of the bicep tendon out of plane. So again, bicep tendon within the bicipital groove. You can do it like this as well. So you center it again in the center line, and then you can go straight down to get into that bicep tendon. And here is another way to look at it. So out of plane, they still did it in cross section, but they still did it in plane with your needle. And you can see where it's filling right around the bicep tendon, the long head within the bicipital groove. This is, again, another AAFP picture about how they do it blindly. So again, you can palpate that bicep tendon. You can put in steroids blindly into it. I also do a lot of PRP though nowadays, and almost everything for PRP is under ultrasound. Now let's move on to the knee. Okay, there are 4 different knee injections that I have listed here. Maybe 5 actually. There's one extra bonus one I think I added. So I actually tell my residents that they should always palpate the patient to feel if they're better, got a bigger space, superior medial or superior lateral. Sometimes it's actually inferior medial, inferior lateral. With an ultrasound though, what the best thing is, it kind of depends if you're just injecting something or if you're actually looking for fluid. Your ultrasound is really useful. So you can see here's the patella and it's right at the edge here and it's watching the needle as it goes right under the patella to do this injection. This is the subpatellar view. So this is, if you're looking, your quad tendon is up here, and what you're doing is looking at this patellofemoral space behind the knee, and you can see there's some fluid there. You won't always see fluid, but usually there's a little bit of fluid, and that's actually another good way to do this because you're coming in from the sides along the quad tendon. I was taught in my ultrasound class to go through the quad tendon, which I never do because I think it's really mean, but that's another way you can do it as well. So here again is this retropatellar view. So here's your nice patellofemoral groove, and then your needle is going to come from out here and come right down to there to get into there. Okay. This is the knee. Sorry, I'm going to bring my knee up. So this is the knee joint this way. So with a bent knee, and you're going to actually put the probe up and down on your knee, and you're looking at it this way. So this is the joint space. Sometimes, and actually it's pretty accurate, you can see peripheral meniscal tears this way. And so you can kind of see the extrusion of the meniscus pushing out sometimes. But this is another way to do your injection. So usually I have them with their knees bent, hanging over the edge of a bed or a chair. And then, let's see if I can see it. And so like this, knees bent, ultrasound goes right on it. I tell a lot of people that these are good injections to do with an ultrasound when the anatomy is difficult. So when people have, I tell people it's a fluffy knee and it's hard to actually palpate your tibial plateaus on each side, or even sometimes it's hard to feel around. So sometimes to even get into the joint, you really do need an ultrasound. And so this one is out of plane and you would go straight into the joint that way. So this is the knee out of plane again. The next is a Baker's cyst. So this is the bonus one that I found. It basically is a ganglion cyst that forms in the posterior medial knee. Usually when you have a lot of fluid in the knee, it almost always forms this Baker's cyst. Under ultrasound, it's really nice because you can see the size of it. So I usually like to ultrasound just to make sure there's enough fluid for me to actually drain out. The other thing it's nice for is you have your needle in there. Always I numb it up first, but usually this looks like a numbing needle, so really thin. And then I use a bigger needle, so an 18 gauge, to aspirate the fluid out. And under ultrasound, I can actually watch the fluid as it gets sucked out, and I can scan it and make sure that I've taken all the fluid out of that cyst. Again, these are some options that you can see for superior medial, superior lateral injections. This is from AFP, again, how you would do it without an ultrasound. So the knees, I often do without an ultrasound. Sometimes I feel like it gets in the way. If you can feel your anatomy, it's not always necessary, but it is nice and it's fun when you do it. This is one that I do commonly, is a pes anserine. Definitely you want to palpate it right where your semitendinosus, your sartorius and your gracilis. Those 3 tendons come down and insert over at Gerdy's tubercle. So this is Gerdy's tubercle. Pes anserine comes down. You can actually see a little bit of the inflammation right here, and then you can watch the needle as you inject your steroid into that pes anserine bursa. This is again an AFP picture showing the needle being injected with a extended knee without an ultrasound. So again, they go down to the bone and withdraw 2 to 3 millimeters, then you can inject. So sometimes I'll do this one with an ultrasound, sometimes not. IT band is another common one. So this distal IT band is really thick and it gets really angry. That inserts over at Gerdy's tubercle. So that's the bump also on the below the joint line, but on the lateral side. So pes anserine is on the medial side, and then your IT band is on the lateral. Anyways, you can find the IT band and you have a little bit of bursitis, and that's where the steroid goes in, right at that point. And again, this is a distal IT band again, and you can see how thick it is. And this is how to do it without an ultrasound. And again, point of maximal tenderness and at Gerdy's tubercle. So we're going to stop here. If I am available, I'm happy to answer questions, or you can just let me know, leave it in the comments, and I will try to answer any questions you guys have. Obviously, if you're at the class, then the other instructors there should be able to answer any questions. And then now we're going to move on to the shoulder models and the knee models and to practice doing the actual injections under ultrasound. Practice makes perfect. So the more you practice, the more you do it, the easier it is. One of the most important and difficult skills for ultrasound guided injections is keeping the needle in plane the entire time. So there is a model that we have at the class where you can practice just keeping your needle in plane. Again, if you have questions, please leave it in the comments and I will try to answer them. Also, if you guys would like to, you can always access this video, stop it, rewind it, go rewind it to the place where you had a question and you can review it again. Thank you for watching. Let me know if you have questions or concerns. Thanks. And this is my bibliography.